I think that one's going to hold. I'm still admitting people here. Okay, I think we can start. So good morning, everyone. Those of you who don't know me, my name is Roger Tam. I'm the director of the Engineers and Scrubs program, which is a graduates level design and innovation program that we have here at UBC in the School of Biomedical Engineering. I'd like to extend a welcome to our guests from the MedTech Talent Accelerator program joining us this morning. We're very happy to have you here. We're very privileged today to host this seminar on rural and global health. And we have three distinguished speakers with us this morning. So I'll just read these brief intros. Dr. Harvey Haas is a trauma surgeon, humanitarian, and entrepreneur dedicated to improving people's health around the world. He mentors surgical residents and fellows globally and is the executive director of technology at Innovative Canadians for Change and co-founder of MedTech Technologies. Dr. Ryan Falk is a family physician whose area of practice is rural surgery and rural generalist medicine in the Beaufort Delta region of the Northwest Territories, where his patients are primarily from Indigenous populations. He is committed to improving surgical services in rural and remote parts of Canada. Dr. Falk is also an adjunct professor in UBC's branch for international surgical care, operating as part of the instructional team for Surge 518, which is surgical care in Canada's rural and remote Indigenous communities with global comparisons. And Dr. Matthew Wiens is an epidemiologist and public health researcher working out of BC's Children's Hospital, and he focuses on deriving and validating clinical prediction models for post-discharge mortality among mothers, newborns, and children in Uganda. His team at the Center for International Child Health developed smart discharges, which uses a mobile app powered by data-driven prediction models to identify vulnerable children who need extra support after discharge from hospital. So basically, yeah, Tanya's already explained how this is going to go. We're going to have our Dr. Haas and then Dr. Falk and then Dr. Wiens. And then after each speaker, we'll maybe take one or two pressing questions. And then at the end, we'll have a Q&A for all of our speakers. So if there are no other questions or comments, we can get started. Dr. Haas, whenever you're ready, I will enable share screen. Yeah, we're good to go.
Great. I apologize if my phone goes off. I'm not really on call for trauma, but if there's a plane crash, I will be. I might run at that point. Okay, so I'm going to talk. I think I have 15 minutes. Is that right? So I'll try and keep it short. I do go long. Feel free to cut me off. But I wanted to start with something a little controversial, especially presenting it to this group of people. So the title is "The Technology is Not the Solution." Thanks for having me here. I should start by, thanking you for letting me talk. I'm a huge fan of Engineers and Scrubs. I always have been. I'd like to be more involved in it, and this hopefully is the start of that. But I think it's the right way to go. In fact, it's inspired me so much that we have started now, we're in the second year of training our surgical residents how to think like engineers. And so it's a little bit the mirror image of what you guys are doing. And we're having our second annual Surgical Innovation Week, November 29th of this year. That is a whole week of training for surgical residents on innovation, design thinking, iterative thinking, and getting them out of the sort of traditional medical mold of writing papers. I actually want them to solve problems. And so in the future, hopefully next year, I'd like to talk to you, Roger, more about cross-pollinating engineers and scrubs and our surgical residents and start building teams around that. So look forward to that. And I'll admit, this is a bit of me on my soapbox. This is all my biased opinion, so take it for what it's worth. And feel free to challenge me on it. That's why we're here. So repeat after me: the technology is not the solution. Okay, what do I mean by that? Well, I'll give you a bit about my history. Last night I was making these slides, and I started thinking about all the things I'd done for money. And every one of these things I've listed here, I actually received more than one paycheck for. And I realized I've done a lot. And I've done a lot in different fields, and I've done a lot at different levels. I've done it all the way from paperboy, employee type stuff, laborer type stuff, all the way up to a little bit of art work, all the way up to technical work, software development, medical researcher, trauma surgeon, entrepreneur, and even landlord. So I think I have a bit of an understanding of the world. I'm not saying I did any of these things really well, but at least I understand a little bit about the challenges in most of these areas. And I think that's been a benefit. And I'll put a pitch out there. I have a stepdaughter who's 22 who had a very different upbringing. She didn't have many jobs. She didn't do many things outside of a couple of really interesting things to her. And I'm a little worried that she's not going to have that understanding of the world. Turns out she actually does, and it's probably due to the fact that the internet was part of her life early on. So she could see and sample parts of the world that I could never do when I was young. And so hopefully you don't have to have this list of things to be successful in life, and I'm sure you don't. I became a surgeon I think I finished my training in 2010 at U of A. That's general surgery. Then I did acute care surgery, so that means they only call me if someone's really sick. And then I went to Houston and did trauma surgery, and that means they only call me if someone's really dead. And I finished my training, and I was ready to go out in the world. And this is a picture of not Houston, Texas skyline. This is actually a picture of the Texas Medical Center in Houston. Every one of these buildings is a hospital that's bigger than VGH. And so that gives you an idea of the scale of innovation that's happening in the US over the border. They have a $1.5 billion innovation center that they've just built. We don't have that in Canada. We don't have anything like that in Canada. But I want to be part of the group that builds that in Canada. So look forward to that. Then I got a job here at VGH. This is my colleague, Morad Hamid, back pre-COVID when you could actually stand there like that. And this is dealing with a trauma patient in the trauma bay. And you can see the teams, and you can see the teams are embedded in technology. I think that's a very important point, is that everything we do now in medicine revolves around or requires a large amount of technology. And I also want you to look at the technology in this room. It all looks like it belongs here. I think that's an important point that developers and designers and engineers forget, is whenever you make something for a context, the people in this room, when they look at it, it can't stand out as not being something that belongs there. It has to belong in that situation. And there's a reason why it looks this way. And so we'll get to that in a minute. So I got a job at VGH. We have some of the best equipment in the world. This is a big giant robotic arm that can scan patients in the OR in real time to figure out what's going on in them. So we have some pretty fancy toys. But I got interested in global health, and I thought I would take all this advanced training and knowledge and, traipse around and give it to everybody around the world, which is what a lot of young trainees do when we feel guilty about what we've come out of. And then I quickly realized that the places I was going were very different than the places I trained. I was unaware of this. And I think a lot of our medical trainees and graduates are unaware of just how different the world is from where we practice. And I realized that most of the stuff I learned with all that fancy equipment and technology wasn't applicable to most of the places in the world I was traveling to. And so how could I be a physician in an island like this when I didn't have that big robot or the big set of equipment? How does that work? And so I spent the next 6 years of my life exploring that. One example of that, is I was in Fiji, which is that island set that you saw there. And in Fiji, they were just talking about starting something called laparoscopic surgery. So in Canada, if I take somebody's gallbladder out, it's the most common operation we do. I use ports and I put a camera in and I get a view that kind of looks like this. And that's the gallbladder there. And that's some equipment that I'm using. And I basically put some clips across there, take the gallbladder out, and the patient goes home the same day. And I have very little pain after surgery. And I have a better view of what's going on. And the cost to the healthcare system, it's much lower because I can do many more of these operations in a day. And the patients don't have to take a hospital bed up, and they use less painkillers. And then for the economy, they go back to work faster. So laparoscopic surgery came out in the mid 80s, and it changed, it really revolutionized surgery. This is the old way of doing it, where you make a big cut in the patient, they have a big scar, they have to stay in hospital 1 or 2 days, sometimes a bit more. Sometimes patients can't tolerate that big of an operation. And so you can imagine the resource utilization for this patient is very different than this one. And in Fiji, they didn't have laparoscopic equipment at the time I was there. And so everybody was getting these kind of surgeries. The problem was they only had 10 operating rooms for the whole country. At one time, only 7 of them worked. And of those 7, 4 were being used for obstetrics. So that left 3 operating rooms for an entire country per day to do surgeries. And they could only get 2 of these done in a day. Whereas if they did this, they could get 9 done in a day. So you can see technology does change things. I happen to be on the North Island in Fiji, and an American university donated one of these towers, which is a laparoscopic tower. That's all the equipment you need to do laparoscopic surgery. And I was one of 2 surgeons in the country that knew how to do laparoscopic surgery. So we were pretty excited. We thought we'd unpack this big box donation and hook it up and get doing laparoscopic surgery there. The problem was, and this is the failure of the donation model, is that little piece right there was not in the set. That is an adapter on the fiber optic light cord that connects the light source to the camera. Without that, you can't see. But if you can't see in laparoscopic surgery, you can't do laparoscopic surgery. That part was not in the box. So we called the university that donated it, and they said, well, we haven't used those kind of light cords for a long time. We can't find the part. Maybe call the manufacturer. So we called the manufacturer, and they said, well, we don't usually sell them independently. We sell them as part of a service package. That's $30,000 a year, to which Fiji said, we can't afford that, which they always say when they get offered that solution. And so that piece of equipment that you saw is now sitting out in the rain behind the hospital and was never used. And it was just added to an entire parking lot full of equipment that was never used. So I started thinking at that point, well, if I just had one of these things, I could print that part and we could change surgery in Fiji. Or if I was even smarter, I would redesign laparoscopic surgery for that context. I would make it so it was lower cost, simpler to use, user serviceable. And I might have a catalog of licensed 3D parts that you could print in Fiji rather than having a service contract. And that could be a licensed agreement and you print what you need, and it's much cheaper to do that. So if I were to redesign the system, that's what I would do. And so repeat after me, the technology is not the solution here. Donating laparoscopic equipment, which is the technology, did not change laparoscopic surgery or introduce it to the country of Fiji at that time. And that's because there's more to the story than just that piece of technology. You have OR shortages, like I talked about. You have staffing shortages. You have to train people how to use this technology. They've never seen it before. You need service agreements. You need to have new referral patterns because you need to refer patients to the surgeons that know how to do that surgery. And there's new healthcare costs. The consumables that are used for this operation are really one-time use, whereas the old surgery, it was all reusable stuff. And so there's a huge cost to that. Even though you're having shorter hospital stays, you're having more operating costs. And that often gets missed when people introduce a technology to try and solve the problem. They don't really understand what it means to introduce a technology into a system. I have more examples. So I started my first company, MedTech Technologies, and it was really designed around or thought around the idea that there's new design methods and new manufacturing methods that can change the game. things can be cheaper to design. You can have faster design cycles. You can iterate quickly now with additive manufacturing and prototyping equipment or subtractive manufacturing. You can make bespoke stuff. You don't have to have a big press or a mold made and then do massive runs of manufacturing. You could actually make, and especially as the technology gets better and cheaper, you can make one-offs or 1,000 copies of something and make stuff that's actually needed. And then you can license entire libraries of stuff and have it manufactured where it's needed. You could have a print shop in Fiji. You can have a print shop in Nairobi. That really changes the supply chain game. And so you can essentially democratize medical device creation, and you can put it back in the hands of the people that actually need to use the stuff. You're not putting it in the company that's selling it to you that or is telling you that you need to use the stuff. I get very frustrated when I walk into an OR and I get handed a piece of equipment that I've never seen before, but it's because some manager, OR manager, has had some licensed agreement with Medtronic or something, and they say, this is what your surgeons need. And I've never used it before. I'm putting my patient's life at risk using something I've never used before. And I never asked for it. And it's very frustrating, but it's very common in medicine to do that. So I created metric technology to try and flip that model so that the people needing it can actually say what gets used. Then I got, unfortunately, into this. This was with Icy Change. It's the NGO that one of the directors of. And in 2013, there was a big shooting at the mall. Maybe you remember this. So many terrorist attacks these days, how it's hard to. Essentially, 4 people went into this giant mall and killed everybody or most everybody inside. Unfortunately, it was a bring your kid to the mall and have a pancake breakfast day. So many of them were children. And we had been working with, this is the Kenyan Red Cross Society. This is actually an actual photo. I thought it was advertising. But that's Abbas Goulet, a good friend of mine. He used to be the director of the Kenyan Red Cross Society. And this is James Kissy, a good friend, a physician. And they were in the heat of the moment dealing with all of these injured and dead people. And they called us and essentially said, we have all these patients we're pulling out of this place. We don't know where to take them. We don't have a system to put them in. We don't have a hospital that can accept them with trained people. And so they wanted us to build them a new trauma hospital. This is not that hospital, but they wanted us to build a hospital in Nairobi just for trauma patients. And we said, no, technology is not the solution. What you need is a system to put those patients in. And so we gave them a system and helped them write policy. And now they have a trauma and injury framework where they can tier their hospitals, and each hospital has different capabilities and training, and they have communications and referral patterns and command centers. And now they can deal with trauma. And then now that they have that system, they can place technology in that system and they know it's going to work. Rather than they get donations of more ambulances, those ambulances need a place to drive to. And now in this framework, they have a place to drive to. So we said, don't build a new hospital. You have a hospital that's massive and it's overrun and it's understaffed and it's underfunded. Why would putting another hospital change any of that? What you really need is the system. And so we helped them build the system. Again, technology wasn't the solution. It was the system that was the solution, and the technology to support it. One thing I learned in Nairobi was this place called iHub. It's pretty world famous, although I think it got bought out recently. And it was just really interesting to see how innovation is rampant in East Africa and really around the world. They think much more innovatively than we tend to. I find that my trainees tend to think traditionally, and they tend to think by the career path they've chosen, and that doesn't happen, at least what I saw in iHub. So I was really excited to see this Darwinian natural selection of ideas getting picked, and then big companies standing there waiting to fund the big solutions. I think that's very important. And they were listening to the problems that the Ministry of Health was bringing. It was fantastic. Go there if you can. Then this happened, and I got involved. I have respiratory background as well, and I got involved in the whole ventilator panic. And some of you were involved in that too, and we had many discussions about it. And really the discussion was, we're all going to need ventilators. Doctors were asking for all the ventilators. Governments were saying we don't have any ventilators. And then the makers jumped in and said, we can make those. Those look easy. And then the grantors said, okay, you make them. We'll give you hundreds of thousands of dollars. Go for it. And the VCs are standing by waiting to put money into companies. And the regulators opened up and said, well, we'll put all these emergency use authorizations in, go for it. And myself and my colleagues were saying, let's just take a breath and look at this problem from a different way, the way that I'm typically using. And these are devices that were being produced, and some of you may have been involved in some of these. I was certainly involved in the bottom one, and basically putting the brakes on things. And I wrote a paper with a bunch of really smart people, and way smarter than me, that just basically said, we acknowledge the fact that everybody wants to help and we feel powerless in this, but doing something is not the answer, and pushing technology is not the answer. And it's the same thing that we keep talking about in this talk, is you need to have the system in place. And the reality was, we didn't need new ventilators, and we certainly didn't need new maker ventilators. Well, we have ventilators, and we have good ventilators, and we have ventilators that work. We just needed people to make more of those, because we already know how to use those, and we already trust those, and doctors will reach for those and put them on their patients. I can't imagine a physician reaching for this. I can't see it, because what happens when the patient dies? And who's liable for that? It's the physician that's liable for that. And the physician has no assurance that this was made by anybody that understands anything about it. And so that was the big problem. As tempting as it is to do this, and this is really innovative. Let's not gloss over the fact that this is a pretty cool design. Talk about low-cost manufacturing. You could put this in the rest of the world, but this is scary because it will kill people. And who's responsible for that? And how does the liability happen for that? So again, the technology wasn't the solution. It was that system that's in place. So now I have a new approach coming to the end of this. The first thing is, I'm sure I don't understand someone else's pain until I ask them, okay? If I don't ask somebody what their problems are, I'm not gonna be able to make a solution. And I know in Engineers and Scrub, you guys really adhere to that. And I think that's great. I also understand my limitations. I can't do everything. I can only do some things well. And so I need to find people to support what I'm doing. I won't make anything that doesn't have a PO number attached to it. That's a bit of a bold statement, but if someone's not willing to buy it and use it, why am I making it? I won't push crap into the market because I don't want to kill patients. I want to be pulled into the market to do good. I want to be asked to help and bring the resources I can bring to something. So I think these are things I always ask myself, or always tell myself when I get involved in a project. It's very important to think about the purchaser, the user, and the patient. They're three different entities, and they all have different needs and values and wants and desires and motivations. And again, think about who's going to reach for what you make in the heat of the moment. When I'm saving a life in trauma, I'm not reaching for the new shiny thing. I'm reaching for the thing I know that works. And I know it works because I've used it before and it makes sense. And so that's coming down to that idea that culture matters. Things need to look like they belong where they're being used. That's a cultural thing. If a nurse looks at something and says, that's really, it could be the best design, it could be the most feature-rich thing in the world. If they look at it and says, I don't know what that is, it's going to go in the waste bin. It's not going to be used. Ask more than one person about a problem. I'm a little worried when engineers come to a clinician and say, great, let's help you design this thing. And they don't realize that the clinician doesn't really know what they need. And they don't really understand how to design a new thing. And each clinician, each surgeon has a different way of doing things. And so designing for one surgeon, the next surgeon in the next operating room will say, well, I never do it that way. Why do I need one of those? And so ask more than one person about the problem. And then only pick things that have impact. Okay. And I'm not talking about financial impact. Like if we're going to be in healthcare and we have limited resources, everything we should do should try and save the world at some level. And so think about that. And I agree that the program that you guys are in and this group is the right group to think about that. You do think about this in ways that I've never seen before, and it's really exciting. So I'll just finish this off. Most of this I've said. Spend more time at the problem assessment or pre-design phase. Respond to those needs and do something called directed innovation. Research can wander freely and discover new things. I think that's what research should do. Innovation needs to solve specific problems, and great innovation solves common pressing problems in many contexts at an affordable price. That's great innovation. That's what we should all strive for. And so put that pad away and ask someone, what are your top problems? What are the top 3? And solve those. It's that simple. Don't make something and then convince somebody that they need to use it. That's the wrong approach. And so I started this group called LHS Labs. We're taking on these big, massive, complex problems right now, the ones that nobody else wants to take on. And they're very much systems problems, but they have big technology solutions that are needed for them. We're also thinking 5, 10, 20, 30 years in advance. We're going to start these things called the blue sky sessions. That's where real cool technology that isn't ready today, but maybe ready in 5 or 10 years, will change the way medicine is done. And we're hoping to have those discussions with innovators. So come find us. Do I have projects? Sure, I've got projects. We've all got projects. Come find me if you wanted to get involved in any of these things. You can have my slides. My email address is at the end of it. I welcome any questions.
Thanks so much, Harvey. I'll make a quick comment to start, which is your statement on being very aware of the purchaser and user and patient. It's so highly relevant to us, and we actually have a workshop early in the new year that's being run by Entrepreneurship at UBC, and even though it's a completely different set of expertise, this is one lesson that they emphasize to us all the time, which is, what they call it the buyer mapping process. So the terminology is very different, but the lesson is very much the same. Is look at the chain of what you need to do to get your product into the market, and if something doesn't make sense, then you have to really examine it. So thank you for bring your perspective, especially from the perspective of global health, which is honestly not often closely examined in the business of context of business development. So thank you for that.
I see a question.
Yeah, hi. Yeah, so I was wondering, so you talk about giving like a system as a solution. What exactly does that entail? Is it like very policy kind of orientated?
So a system in my mind is the framework and machinery that needs to be in place for the technology to work successfully. It could be something as simple as a hospital policy that needs to be updated with a training and in-service training session with the nurses that are going to use the equipment. It could be something that happens at the provincial level where it's an accredited piece of equipment and they want to standardize it across the region. Something like an electronic health record is in that sense. Or it could be, like I did for the Ministry of Health in Kenya, where it's in a national policy level framework. And then the gaps or the little pieces in between, like usually around communication or data handling or those sorts of things, that's the technology that can go in to support that. So the system is varied, can be very small, or it can be very large. It depends on what you're developing for.
Okay, thanks.
More questions. I don't know how many you want to take, but let's keep going. Maria.
Yeah, thank you. It's very inspiring. You talk about system, sort of like logistic and system changes in order to, and it's not the technology, right? You need to create the system that can host technology. If not, it wouldn't be accepted. But you talk about examples that are very complex in the sense that they require the collaboration of a lot of people, and obviously, the question comes, who do you think is actually qualified to do these changes? And maybe if you could give a little bit more of examples of more of like a small scale sort of a system
Sure.
change.
So I know it's confusing and it's scary, and healthcare is really complicated, but you can break it down to there's healthcare funders. Those are people that fund healthcare. They're either insurance companies or in Canada, they're governments. There's healthcare providers, and those are things like Vancouver Coastal Health Authority or the physicians or the nurses that are in it. So they provide, they do the service of healthcare. And then there's patients, they're the consumers of healthcare. And so I think if you think about it in that way and address your technology to those groups, you'll have a better understanding of how it fits into the system. So for example, funders are going to only pay for stuff that's cost effective, that is reliable, that's serviceable, that, you know, all the things that they need to do to make sure that they're on budget. The providers are going to only pay for things that are easy to use, durable, give good results, that are safe. And then the patients are only going to want stuff that is, you know, easy on them and safe. So all of those people have different motivations, and you need to understand that. Who is best responsible for that? In my mind, it's the health authorities know best what they need. And those are the people that you need to be talking to. They build the system in which things are working. I see a lot of innovation going through the consumer and then being upscaled to healthcare. Google's been trying to do that. Apple's been trying to do that. That's not going to work in any major healthcare system unless a healthcare authority signs on to that data sharing platform, for example. So you really need to think about the healthcare provider and the funders before you introduce something. Hope that helps.
Yeah, thank you so much.
One more, Mary Jo.
Yeah, I had a question. How difficult is it to innovate new devices in other countries due to their different healthcare standards and regulations?
It's a lot easier. It's so much easier. First of all, they use standard regulatory pathways. So for example, Kenya will use the ISO standards most commonly, or the British standards. So you still have to meet the same regulatory assessments that you would normally have to do, but they're much more willing to adopt leapfrog technologies. And, you know, the classic example is the telecom company in Kenya, it's Safaricom, introduced something called M-Pesa, which was an online payment system back in 2007. And we still don't have that here really in any sort of state. So they're very good at leapfrogging things that require a lot of infrastructure, because they don't want to build the infrastructure and then just dismantle it again. So it's very easy to get adoption of new technology. The standards are essentially the same as anywhere else though.
Thank you.
Fantastic. Okay, so let's move on to our next speaker, Dr. Falk, whenever you're ready.
Yeah, sure. Let me see. I'll just that came up for everybody, eh? That's the right way around. The slides there. It's over my video image. Yeah, I see some nods. Great. So thank you for that, Harvey. That was really interesting, and I couldn't agree more. The whole perspective on technology and how it should be used. And as a rural physician up in the Canadian North, we have more technology than a lot of the low middle income world would have, but a lot less than you would have in Vancouver General. So often with our family medicine residents and medical students, we talk about, should we get a CT scanner in Inuvik, which is pretty much just taken for granted in most of Canada. But then we'll have conversations about, well, how will that change our practice? And when you think about how technology has improved how we deliver care, but also how it's transformed how we deliver care. And it all really started with this thing, which everybody knows. It's kind of the iconic symbol of a physician. But this sort of began a change in the relationship between doctors and patients. And that's just been continuing with technology. It's a whole other thing we could talk about, which I think is fascinating. This is kind of representative of a physician today, but if you go back a few hundred years, it was a urine flask. I have no idea what we'd use that for nowadays, but that's just how sort of things have changed over time. So this is sort of my title here was Circumpolar and Global Surgery, providing surgical care in the Western Canadian Arctic. And I'll talk a little bit about me, but not about me necessarily like Ryan Falk, but a bit about the kind of physician that I am, the kind of care that I provide, because it's probably new to a lot of you. It's even new to a lot of physicians who are more based in urban centers. And then a bit about my practice environment, which I think is a really interesting, unique place. If any of you have been up in the far north, you'll understand that. If you haven't, you need to go and visit the north of this country. It's a beautiful, fascinating place. And then a bit of some of the research and some projects that I've been involved with related to my practice in the north. So that is my wife and myself. My wife is a family practice anesthetist. and I'm what's called an enhanced surgical skills family physician. If you've heard the term GP surgeon, that's kind of an older term, but that's basically what it is. And to be one of these kinds of physicians, it really is all based in what we call now rural generalist medicine. And you could think of that as the modern version of the old-fashioned country doctor. And this is a graphic from the Australians. They've really branded this term. And us in rural Canada and rural Australia, we have a lot in common. The geography and the issues of care are very parallel between our two countries. And so as a rural generalist, these kind of like these do everything family doctors, primary care is at the center, as you can see in this image, but we also provide emergency medical care, we provide inpatient hospital care, and we also have a population public health lens to whatever we're doing. And you could do this in a city, but it doesn't really work as well in the city because you have all of these specialists and subspecialists, and sort of the subspecialization in medicine is another trend that is a whole other topic that we could talk about. But as a rural generalist, you're providing all of these aspects of care within the rural context. And then there's some advanced skill set you're trying to insert into that system. So in my case, it's providing surgical services. With my wife, it's anesthesia. You could be a GP oncologist providing chemotherapy in your community. So there's different aspects or ways. So one of the things about this type of medicine is it's trying to bring specialist care from the tertiary care center down into your rural community and trying to get more care close to home. But it's a limited scope. So I'm the ESS physician, but I don't do all of the surgery that Harvey would do. And it wouldn't be appropriate for me to. I don't have his training, and it's a totally different context. And we'll talk a little bit about what we do in Inuvik. This is a statement from the article that the little graphic came from. Rural generalist medicine defines the best model of medical practice for a clinical context in which patients do not have easy access to a full suite of specialist services and resources. In these contexts, if quality care is to be upheld, the medical practitioner has a heightened level of responsibility to meet community needs. This clinical context is typical of most small, rural, and remote communities and equally applies in a broad range of global contexts. So I think that's probably fairly obvious, but I think it's also important to put that out there. And that's how we think in rural Canada. So myself, I'm an enhanced surgical skills physician, the first line there. There's a group who do surgery called obstetrical surgical skills. So that's more based on the cesarean section. A lot of rural surgery in Canada, it's really all focused around providing maternity services and keeping obstetrical care local. And you hear lots of stories in the media where a hospital closes and then the women can't deliver in that town. They have to go to a higher level center. And then over the next, say, 10 years, the town basically collapses because it's hard to have a local economy if you don't have young families and families who can stay in that town to get that kind of care. And then family practice anesthesia is another one where what my wife does, and much of anesthesia in Canada is provided by these family practice anesthetists. So that's a bit about sort of rural generalist medicine and sort of these enhanced skills within family medicine. Most of these enhanced skills are 6 months to 12 months of a third year of residency. And all of this, I think, putting it in a bigger global context comes down to something called task sharing. I'm not sure if that's a term you've heard of. So taking another bigger step back, kind of where this all came from, and this will tie in a bit too with something Harvey mentioned about innovation in East Africa, but this is not so much technological innovation as systems innovation. So this is obviously a map of the world. The darker the color, the worse the access to surgery. And it's a pretty abysmal statistic, but they say about 70% of the world's population has little or no access to timely surgical care. So that's where you have moms who are dying in labor, the baby who's dying in labor because they can't get access to a C-section. You can have young men who are farmers who have massive inguinal hernias and they can't work on their farms because you can't lift much and do much if your scrotum is that big with your intestines in them. And that's all preventable stuff. And then those patients too, the bowel can twist and then that person can become quite sick and die from that. So that's what this map represents. But it also, on the flip side, it represents where there are fewer surgical care providers. And of course, surgical care is a lot more complicated than just having a surgeon who can do the surgery. You have all of the system and the infrastructure, which also this relates back to what Harvey was talking about, in which those healthcare providers function. So one of the solutions to trying to increase the numbers of surgical providers has been through task sharing. And this is just another quote from the World Health Organization and the Lancet Commission of Global Surgery. So task sharing is the rational redistribution of tasks among health workforce teams from highly qualified workers to health workers with shorter training and fewer qualifications, where both the specialist provider and the provider with less training share the responsibility for a high quality outcome of the task. So in the high income country setting, like say Canada or Australia, I would be a task shared physician because I do a C-section in Inuvik rather than an obstetrician, or I'll do an appendectomy rather than Harvey. And it's a bit more complicated than that, but that's generally sort of the idea. So task sharing is an important concept in terms of rural surgery anywhere in the world. And then this is a quote from another article. The use of these practitioners is the only feasible route to deal with the huge lack of primary surgical care in low middle income countries as well as elsewhere. So I think that's just an interesting sort of global picture perspective, and something I gained by partly by working in the North, but also through the Masters of Global Surgical Care program at UBC. My practice environment. So I'm sure all of you can find the Northwest Territories on the map. You might not know where Inuvik is, and that's up in the northwest corner of the Northwest Territories. So kind of near where the Yukon narrows up to the Arctic Ocean and Alaska is just a bit up. Inuvik is not Iqaluit, which is in Eastern Canada, and it's not Nunavik, which is a region of Quebec, which is also an Indigenous region. Our population is majority Indigenous, and that's the Inuvialuit people, who are a Western Inuit people, and also the Gwich'in, who are a Northern First Nations group. So you have the First Nations and the Inuit people up there. And it's an amazing place to work. It's a really friendly community. It's probably one of the nicest places we've ever worked, which is why we moved up there. And you can see all the little red dots are remote communities. So Inuvik has about 3,200 people. And if you add up all of those little red dots, you have about another 3,000 to 4,000 people. So our total catchment is about 7,000 population, and quite spread out. And then Yellowknife, further down there is Yellowknife. That's the capital of the Northwest Territories, and it's our referral center. But they're not a tertiary care center. So if we need tertiary level care, patients have to go to Edmonton, which is off the map. Everywhere south of Inuvik, people up there say, oh, this is down south. So Yellowknife is down south. Edmonton is down south. It's a very different perspective when you're on the north coast of Canada. And another perspective, this is tying in a bit too with the global surgery, is global surgery, we often think about kind of that north-south kind of comparison. And global surgery also includes, say, the circumpolar world. And so this map represents the circumpolar world. So all of the world above about 60 degrees latitude. And the red circle, of course, is around the circumpolar Canada. But you can see all of the other countries around the globe that also have circumpolar areas. And this is not a very well understood area in terms of healthcare delivery. This is the Inuvik Regional Hospital with a nice sunset. This is a different time of year. It'd be much colder on this day. So, I mean, the weather introduces some challenges. I'll show a bit more there. This is our operating room, which will look like any other operating room in most of Canada. They're not as fancy as Harvey's because this isn't a tertiary care trauma center. But your average community hospital in Canada would look like this. And one other comment here is if you look at the OR table, this is our new OR table. Until maybe a year ago, we had an old-fashioned hand crank OR table. So if you had to bring the legs down or bring the bed up and down, it was a hand crank. So just speaking of old technology. This is our endoscopy suite. So for like gastroscopies, colonoscopies, for gastrointestinal endoscopy, we have this room for that. At our hospital, I mentioned earlier that in rural hospitals, maternity services are key. So of course we do regular deliveries and cesarean section backup, which is important. We do a lot of GI endoscopy. I just showed you the endoscopy suite. And we do a lot of elective surgery. So for me, an elective surgery would be something like an inguinal hernia, umbilical hernia, vasectomies, tubal ligations, larger lumps and bumps, things along those lines. And we also have visiting specialists. So for example, when the general surgeon comes, they'll do the gallbladder surgery. And we know more about that thanks to Harvey's presentation. GP surgeons, ESS physicians don't do that. That's more complex than is appropriate for us to do. But our visiting surgeons will do some of those surgeries. And then emergency surgeries. So those would be a cesarean section would be the most common, but it could be appendectomies, ruptured ectopic pregnancies, those tubal pregnancies, because they can bleed quite a lot and be quite dramatic. So those would be some of the emergency surgeries that we would commonly do in a rural and remote community. And most of what I'm talking about here is not unique to Inuvik. This would be common for any rural hospital in Canada where they provide surgical services. And then at the bottom there, I just have that note, limitations to what can be done. Part of that is our level of training, but a lot of that too is just the resources. You're not going to take a really sick patient who needs a complex surgery to the operating room in a rural hospital, even if you have a competent surgical and anesthetic providers, because you don't have all of the other perioperative resources you need to take care of that person. We could have a really bad trauma in Inuvik, and if that patient were at Vancouver General under Harvey's care, they would have a lot more done than in Inuvik. We might just decide to hold their hand and keep them comfortable and call them the family, because we don't have massive blood banks. We can't do the same kinds of transfusions and care that can be provided in a tertiary care center. So the kind of care we provide is also very context specific. And I'll talk, I think next is some of the challenges. Yeah, practice challenges, which relates to that too. So I'm putting this in, so this is telehealth. So this picture is to represent trying to take care of patients remotely. So from Inuvik, all those other communities will be talking to patients through telehealth. So that is an area where technology can enable those interactions. And I'm sure over the next 10, 20 years, if even that, the way we can provide this care is going to be dramatically improved. But there's also how can the care that we provide be supported remotely? And then there's a project that Harvey's team is involved with where they have equipment kind of like in this bottom picture, connecting them to rural hospitals in Canada. So if they have a bad trauma in British Columbia, so if they have a bad trauma in parts of rural British Columbia, that rural trauma team can then contact the Vancouver General Hospital team, and they can help them manage that trauma. And in the operating room, they can access the video equipment to see exactly what that ESS physician in a small community is seeing, and do the best they can so that patient can survive what we would call damage control surgery to then get them to somebody like a Harvey for more definitive management. So that's another area where I see technology, at least in a rural setting, being helpful, is how do you enable the care in that rural setting to improve the care to those patients? Weather is often an issue, as you can imagine. Often we can't get patients out because the weather's bad, the planes can't fly. In Inuvik and a lot of the smaller communities, they use something called visual flight rules. So if they can't see the runway from a certain distance as they're landing, they have to go back up again and return to where they came from. And if they're coming to Inuvik, if there isn't an alternate landing site in a certain distance, they can't even come to Inuvik. So we have a lot of challenges in terms of weather delaying getting patients out who need to get to a high level of care, or to us from one of our smaller communities. This is another one that we take for granted in Canada. It's just a ready supply of electricity. And we'll sometimes be in the operating room and you're in the middle of a laparoscopic case or doing a colonoscopy and the power goes out. And then there's a lag until the hospital generators kick in. And Inuvik is interesting. They had a natural gas source reservoir that ran down on these really, really old diesel generators that were converted. And then when the natural gas was running out, they switched to propane. So it's really hard, just infrastructure wise, keeping a place like Inuvik going. And then that has obvious infrastructural issues on the hospital when that becomes an issue. This one is, I mean, it's going to sound funny when I talk about it right now, but it's potentially very, very serious. Up in Inuvik, everything is built on permafrost. So if you walk around town, a lot of buildings are on pilings, so that the building is about 4 or 5 feet off the ground. You can't have a building on the ground because the heat of the building will melt the permafrost and the building will sink. So one of the ways of getting around that engineering technology wise is just having pilings. Some buildings also have something called thermistors, which I don't know a lot about, and some, depending on your engineering background, some of you might know more about that. But there are these devices that help keep the permafrost frozen. Basically, that's my understanding of it. The hospital is on one of these. Has this kind of a system. But even at that, there are these things called pingos, which are basically heaps of permafrost that build up over time. And apparently there's one under the hospital. And this is what a pingo can become. So in a few hundred years, maybe the Nunavik Regional Hospital will be sitting on top of one of these. But that's just another challenge to buildings in the north. So this is from there's actually a national park up near Tuktoyaktuk, and this is from that region. So this is another picture from a project that I had done, but this is looking at medical travel for a patient, and this is an example with breast cancer. And this is just to show you how complex care delivery is, and in my view, the importance of trying to find ways of providing care as close to home as possible. And just to go through this briefly, on the left is the community health center with a community health nurse. So then she contacts us in Inuvik, and this is let's say a patient with a breast lump, and then we will see that patient, or I talk to that patient and organize their next care, which might be a mammogram or ultrasound. Some of that we can do in Inuvik, but some of that has to go to Stanton Territorial Hospital in Yellowknife. And there's all this, the bottom part just represents the back and forth communication between the care providers. But if you look at the green, that is all of the travel for the patient. So to and from Inuvik, to and from Yellowknife, and multiple trips to Edmonton to go see the breast surgeon in Edmonton, to go and have, they might need chemotherapy or radiation therapy pre or post breast surgery, follow-up treatments. And so if you're from a remote community in Northern Canada, if you have to go through that much travel, it's daunting. And a lot of patients will pick, for example, a complete mastectomy, which is a lot more disfiguring than what would be more standard of care breast conserving surgery down south, because they don't want to go through that many trips. So the type of care patients receive is different, often because of these complex decisions. This is an example of the travel journey for a patient going through all of that. So each of those back and forth green arrows, in particular, like 7, 9, 10, 11, 12 there, this happens every single time. And that's just showing you the one direction, and then they still have to get home again. So you can just imagine how, if we had different technology to provide more of this care closer to home, it would really have an impact on care for these patients and their outcomes. We know that the cancer outcomes are worse for Indigenous Canadians, and often later presentations. So that is a bit about some of the practice challenges I see in the North and in rural communities. And then lastly, just some research and projects that I've been involved with. So my main master's thesis project was to do with understanding rural surgical systems. This is a really big focus right now in Canada. So a lot of it has to do with understanding rural population needs and their surgical needs. That's nothing that has really been well studied. And models of delivery for care. And what I do is one example, having family physicians trained with enhanced surgical skills. But there are also a lot of people who say, well, no, you should have a specialist surgeon providing that care. But somewhere like Inuvik is too small to have a live-in-town general surgeon. The volumes are too low. So then people say you should have surgeons flying in and out, but then you lose continuity. And most general surgeons graduating today can't do a cesarean section. That's not part of their training anymore. And that's part of the subspecialization of medicine. So it's really interesting to start thinking about what is the best model of delivery for different communities. And when you start getting to the global comparisons, this is just a book called Turning the World Upside Down by Nigel Crisp. And it's this idea about lessons that we can learn from other parts of the world. I can put the title in the chat if people are interested. So Nigel Crisp was working for the NHS, National Health Service in the UK. And at the time, Tony Blair was Prime Minister, sent him out to say, how can we as the British help the developing world develop better? And when he went out there to go and talk with all of them, he came back realizing they have a lot of pretty interesting solutions to problems that could really help us back in the UK. So it's really that idea about the bidirectional shared learning. So I think that's a really interesting area. That also ties into global surgical task sharing. So we talked a little bit about that, but there's a lot in that. How do you train somebody who is a generalist physician to best provide surgical care? What should they be doing? And it gets a lot into educational theory. There is a lot of work with developing these programs, a lot of partnerships between high-income countries who maybe have the resources to develop some of the training with lower middle-income country settings. So that's an interesting area. And some of my colleagues in rural Canada are being involved in a project in Zimbabwe right now. And then something I've personally been involved with for global surgery is a hernia project in Ghana. So the Shekina Clinic is in northern Ghana. So here's Ghana in West Africa. The blue dot was my phone GPS when I was up in a town called Tamale. And the Shekina Clinic was founded by the physician, the picture on the wall there. He unfortunately passed away a few years ago, but he was a Ghanaian physician. His story is very, very interesting, but we can't go on for too long. And it's a charity-based clinic, which has obvious sustainability issues. But there's been a team of the guy sort of in the middle with sunglasses. He's in his later 70s now and wanting to back out of this project just because he wants to hand it off to some others. So a bunch of us other ESS physicians in Canada have become involved to go there and help support their surgical program. So it's been very interesting and just seeing the parallels between the low resource environments in our different settings. And that is a picture of the operating room. So quite different from the picture I showed you of Inuvik or Harvey's in Vancouver. And usually we just have one table, but you can even see the tables. The one sort of in the front of the picture looks like more of a probably a normal OR table, but the other two just look like other tables, steel tables that they just put some drapes on top of. And even if you look at the lights, most of us wear headlamps when we're there because those lights are very, very poor for quality, especially if you look at the one on the right of the picture. So that's the kind of equipment that they have there. But they still provide, I think, a reasonable quality of surgery. But you can see the difference in practice challenges to try to provide that quality of surgery when those are your resources. So that's what I had. Thank you.
Fantastic. Thanks so much, Ryan. Anybody have any pressing questions? We can take maybe one or two.
They are. So I'm just trying to change my view back. I can't see if anybody has. Okay, there we go. Hands up.
I'll change my view as well. Maria, please go ahead.
Maria, yeah, please go ahead.
Yeah. So if I understand, like you could generalize clinical or surgical care in rural areas having two issues, if I understand correctly. One is specialization, right? How like every surgeon has to be specialized in many areas to be efficient, and also is the lack of technology, right? So for instance, I see why doing radiotherapy or something like that in a rural environment might not be cost effective, for instance, for economically wise. But can you see any particular either traumas or surgical or even long-term care that would benefit from having technologies on site? More like, do you think it's a thing about getting the technology into the hospital or really adapting current technology to be able to grasp a wider range of diseases or needs? I don't know.
No, that makes sense. And it's a combination of things. So I won't be able to give you a simple, specific answer. There are certain things that you'll never be able to do in Inuvik. So a part of it to me has to do with, are there going to be innovations in surgery that change how we do things? And if you take an example of, like say the evolution of laparoscopic surgery and how that's changed things. And a lot of surgery has become safer through innovation. So if there are surgeries that we don't do now because it's not appropriate for me to provide because I'm not a specialist surgeon, if the technology changes to allow me to do other surgeries in a more safe way with lesser training, then you could provide that. You could provide that locally. An example for say with breast surgery. So, most women with breast surgery will have what's called like a breast conserving surgery, where the area of the cancer is removed, but they also do something called a sentinel node biopsy, where it's really looking at the lymphatic drainage and they're sorting out, okay, well, where has the cancer gone to? And let's remove that part of the distribution where the cancer has been draining from. But there are some new technologies, and I don't know a lot about them. A friend of mine does, she's a general surgeon, but India's been developing a different technology that doesn't require the radiation or the technetium. Again, Harvey might know this, or he probably would know this better than me. But when you have to do a certain labeling within the breast to do this surgery to begin with. And this new technology, you don't have to do that. So it skips that part of the radiation. So that could, for example, be offered in Yellowknife. If they need like radiation oncology as part of their cancer follow-up, that's different. But that would be an example of a surgery with innovations in surgical technology that could go from Edmonton to Yellowknife, or maybe Yellowknife even to Inuvik. So it would be things along those lines. But we will never have the resources of Vancouver General Hospital, nor should we. It wouldn't make sense. And if you think about how often we actually would have a real trauma surgery, like something that requires Harvey's level of training, I mean, that might only happen once every few years, if that. So that's also part of the problem. The volumes are low. So it really becomes around how do you best support the team locally to get the patient to survive to get out.
Okay.
And there's more things that we could talk about, like a lot of the military, let's say for managing bleeding, a lot of those hemostatic sprays, like that might be, you open the abdomen, Harvey won't want to hear this, but if you were just to stop the bleeding with some of the hemostatic sprays, which will do, you might be able to get the patient to survive to get out.
Okay.
Yeah, it gets complex, but yeah, it's things like that.
Thank you so much.
No, you're welcome. Yeah, I got a thumbs up there from Harvey. Yeah. So David, I think you're next. Oh, I think you're on mute.
You're right. Sorry, Harvey invited me to crash your party here. We ran into each other at 1:30 in the morning in the hallway of our offices, which is kind of sad. But I just wanted to talk about what you just mentioned, Ryan. As sort of outgoing trauma director for the province, I'm well aware that there are what I would consider preventable deaths. Let's forget about the morbidities, but preventable deaths. Not a lot, but like you said, occasionally that happen because patients are just away from a place like Vancouver General or even Yellowknife. And it's been clear to me for a long time that the only way to change that fact of living in a really dispersed population is to enable people like you to do, I would say a handful. I call them the hateful 8. There are, I think, 8 procedures that if you don't do them with the resources that you have with anesthesia, a moderate skill set, and some simple tools, patients they just won't make it. They're not common, and but they do happen, and they happen maybe once or twice a career around in maybe your career or somebody else's who's working in a rural site.
Mm-hmm.
And so I think a real challenge that has a real need that is scalable to the rest of the world is how do you take somebody with your skill set and provide them just-in-time capability of doing one of these 8 operations. And I think that's a challenge I'd love to see this group kind of start to think about. I've thought about it a lot. I'm sure Harvey has too. I think there are ways that are sort of, there's not one simple solution. I think it's incremental and system-based, like Harvey was kind of getting at, but some of it might be technology based as well. So just to say, I think that's the only way we're going to help someone with a stab wound in the heart or an expanding intracranial hemorrhage. That's there are just a number of big of things that I think are easy to, or not easy, but doable, we'll put it that way. Mm-hmm. And so I'd be interested to see if this group is interested in doing anything with those and what you think about that. Ryan, could you ever imagine yourself opening someone's cranium if they had to?
Well, I could imagine that. And I mean, I've been in, there get workshops where you have models of, crania, and you're opening them because, there's a bleed, and I think most of us in rural medicine know that we'll have to do things that we're not comfortable with. And a lot of our support is having specialists like yourselves that we would be speaking to help guide us with some of that management. And we have a rural procedural book called The Occasional This and That. If you have to do a burr hole to drain a bleed and all of these kinds of things. But a lot of it's having the support of the higher level of care trauma centers to guide us in what may or may not be appropriate as well.
Mm-hmm.
Yeah, imaging technology, because I've heard things like too, there's now like MRI scanners that are using, rather than magnets, using diamonds or something. So I think the medical imaging technology is getting a lot smaller, and that could help us a lot as well, to know what's going on and helping guide the management.
The thing that seems obvious to me would be, something that would allow you to sort of communication and mentoring in a slightly more complex and integrated way than we seem to be able to do now, where
Yes.
you could come onto a platform, we could bring a neurosurgeon, it could be Harvey, it could be, we could have a video for you and show you what to do and remind you, and you'll have maybe done some of this and then help out in the operating, and I think that kind of communication platform is this way to start this in a way that is ergonomic, accessible, simple. And maybe that's that kind of platform. It's not a tool so much as it is, a capability.
Yeah, no, I agree. Yeah, so getting that mentor and coach sort of virtually with you.
Yeah.
To go through whatever might have to happen.
Anyway, really good and interesting talk that you gave. Appreciate it.
Thanks, David. Harvey?
Sure, at risk of hijacking engineers and scrubs by a bunch of clinicians. So I agree with David that complex sort of virtual reality, almost type platforms for real-time communication and embedding the trauma surgeon virtually next to you is a good way of doing that. The other thing that we're looking at, and it's a project that I put out to the engineers and scrubs, with additive manufacturing and multi-material printing, you can start to make pretty realistic, high fidelity clinical skills training devices that because as Dr. Falk was saying, this may only happen once in a career or once every year or once every 3 years. That's not enough skill or repetition to have the muscle memory to do these things, extremely well. But if you had these sort of 3D printed, can be printed locally and manufactured locally for the people that need them, trainers that simulate the procedure that you're going to do, you can practice on those. They can be perfused with, red liquid to look like blood, all the things you need to do to make it as close as possible to the procedure. And you just do them, every 2 months or something. Then when it happens, we suspect that you'll get better at it. And this is scalable across the globe because you can train clinical officers who aren't surgeons around the world on these devices, say for C-sections or these kind of things as well, and hopefully start to provide services in parts of the world that don't have it, the north of Canada being very relevant to the rest of the world. So I think that's a project we've taken on. The added advantage for the engineers and scrubs group is it's non-regulated. And so you don't have to get Health Canada on this. So you can move much quicker and develop these devices really, really rapidly. And so we've actually taken on a project with BC Children's. They have a 3D printing lab there. We'd love to collaborate with other people on it.
That's fantastic. Thanks for that, Harvey. I think just actually recently got an email from Dr. Penny, who I believe is also part of the branch of international surgical care, and he's involved in a surgical simulation project for Uganda, I believe. So yeah, if anybody's interested in that, I'm more than happy to make those connections. But okay, let's go on to our last talk for today. Dr. Weens, anytime you're ready.
Thank you. Let me share my screen here. 1 second. Okay. Oops. All right, can you guys see my screen?
Yes.
Okay. Well, thank you, Roger. It's a pleasure to be here chatting with you guys all today. I'm actually really glad that Harvey had his presentation first, because he sort of gave sort of a global health 101 primer. Technology is not the answer. Totally agree with that. Context matters. I would even say good intentions are not the answer, because oftentimes we see a lot of good intentions causing a lot of problems. And his example with the laparoscopic surgical system that was donated is a classic example of that. And, you know, I've spent many years living in Uganda, and we see a lot of examples of things like that. So I'm really glad that he primed us all to recognize that solve problems, we really have to understand the context really well. So today I'll be talking a little bit about essentially prediction modeling. So we're sort of shifting gears here from sort of a physical equipment and surgery to sort of more sort of an epidemiological perspective. And specifically, I'm talking about what we've sort of called smart discharges. And really that's just a way to sort of understand and be able to prognosticate events after hospital discharge for children who have sepsis. So, where's my slide not working here? So today I'll sort of talk about three main aspects: bit about sepsis and the burden of post-discharge mortality, a little bit about prediction, and a little bit about improving outcomes. And of course, I'll be sort of skimming over this very broadly, so we can get into some more details if you want after the presentation. So just a brief outline. Sepsis is essentially when an infection causes organ dysfunction, and is really the common final pathway to death for most who die of infectious diseases. They, you know, it can be caused by any kind of infection, whether that's bacterial, parasitic, fungal, viral. COVID-19 now is a classic cause of sepsis that is well recognized. But what is the burden of sepsis? They did a study recently published in the Lancet trying to understand what the burden of sepsis was globally. And they found that it was indeed very common. About 50 million cases of sepsis every year. This is 2017 estimates. 11 million deaths. About 20% of all those deaths were in children. And if we look at where those deaths actually occur, we should understand that it's primarily not occurring where the wealth is. If we're looking at issues or at prevention, recognition, and management of sepsis, we have to understand where these deaths are occurring, which really leads me to sort of issues of inequity and why I've begun focusing my work on resource limited settings. So here we see where the wealth is located, primarily in the global north. But if we look at where the deaths are, we see that those are primarily in the global south. And in this case, this is under 5 deaths, and many of these deaths are related to sepsis. The burden of sepsis is concentrated towards those living in settings because there's lots of issues around poorly resilient health systems, poverty, and vulnerability, which create essentially environments where sepsis is difficult to prevent and to manage, which ultimately means that sepsis is as much a economic and social disease as it is an infectious disease. And addressing the issues around sepsis, therefore, is broad and complex. If we look at the distribution of health workers, it's very easy to recognize that we need different models of care to address sepsis. If you look here on the x-axis, we see the percentage of the global workforce. And we see that this is primarily in America and in Europe. But if you see where the burden of disease is, it's where the workforce is smallest. So we have to have different models of care. And this gets back to what Harvey says, that we cannot take solutions that we have found to be effective in our settings and merely apply them to settings where perhaps the burden is higher. It just won't work. So we have to think of new and innovative ways to address sepsis. So I wanted to begin my discussion with the journey of a mother and a sick child. So here you can see all the way from the top left corner, which is in the community, that the journey begins with recognition of illness, and there can be a lot of issues around delays in recognizing the need to seek care. Secondly, once there is a recognition of illness and a desire to seek care, there can be a lot of delays in seeking care related to a lot of things such as cost of transport, geographical barriers, weather, distance, etc. Even once you reach a facility, there can be issues around delays in receiving care, delays in triage, for example. Obviously, issues around low quality of care, and that's obviously very complex as well, related to staffing, resources, burnout, and a lot of other social factors. But even once care is reached, there are issues that occur after hospital discharge, and this is the area that I'm focusing on here. We would assume and would hope that when a child is sufficiently well to be discharged, that they will be okay. But this is really not the end of the story. And indeed, there's very good evidence, which I'll present a little bit to you, that there's more children dying after hospital discharge than die in hospital. Most of the deaths are in community. So we really have to also address issues around health seeking after discharge and recognition of illness after discharge. But this is a very vulnerable group. And this is the area that I'll be talking a bit about today. We look at a little bit of the data that's being published around this, which is not very much. We see that this is indeed true. Here we see a systematic review that I was involved in, looking at post-discharge mortality in children with a number of different underlying conditions, most of which are related in some way to sepsis, to infectious diseases. And we see that each pair of bars, the orange and blue is a single study. Orange represents the post-discharge death, and the blue represents in-hospital death. And we see here consistently in all underlying causes, other than perhaps malaria, that post-discharge death is a significant cause of mortality among children. So this really led me to my work and my efforts to focus on post-discharge mortality. We started this work during my PhD. This would be around 2010, 2011. I was living in Uganda at the time, and we did some initial studies in the southwestern part of Uganda, in a place called Mbarara, trying to understand two things. Essentially, we wanted to understand what is the burden of post-discharge mortality. Second, we wanted to understand, is it possible to predict if a child is going to die after discharge? The idea is then that if we know who these at-risk vulnerable children are, we can intervene. And finally, we wanted to develop ways of improving outcomes during this vulnerable post-discharge period. We did an initial study in 2012, and we found essentially that as many children are dying after discharge as in the hospital, and that we could indeed build some models. And we did build models, and we did some initial pilot work around improving outcomes, which was quite promising. Recently we started a study, this is back in 2016, where we're looking at 4 hospitals in Uganda for children who are 6 months to 5 years of age. And the idea was to validate our previously derived models for predicting mortality in the post-discharge period. We also are doing a parallel study in children under 6 months, which was a different age group that we're focusing on that we didn't focus on initially, to do the same thing. So we wanted to develop and to validate models to improve, essentially to identify vulnerable children and improve post-discharge care. This is then followed by a second phase of our work, which we're now about 2/3 through, which essentially takes our previously derived algorithms, applies them, and has sort of a more individualized response to improving post-discharge care. I'll talk a little bit about what that interventional aspect is later on. But essentially, it focuses around education, and it focuses around targeted follow-up for the most vulnerable during that post-discharge period. So one of the things that I wanted to spend some time talking about today is some of the data related elements, because ultimately you guys are engineers and you're probably interested in data and in probably trying to utilize data to improve health outcomes. So what we do in our projects, it's quite intense. We collect a lot of data, about 200 to 300 variables per child at different phases during their disease and after discharge. Essentially, we collect data at 3 different time points. Number one, we collect data at admission. And this includes demographics, clinical variables, such as like vital signs, for example, social and medical history variables. So this could include things like the duration of their illness, prior hospitalizations, age, sex, like all these sort of basic comorbidities, all other diseases, etc. Some basic labs that could theoretically be done routinely in these settings. So things like lactate, glucose, malaria, like a malaria rapid test, HIV, etc. And then a variety of social economic indicators such as maternal education, access to clean water, etc. We also collect data at discharge. What was their diagnosis? What was their disposition, etc. And then we collect a fair number of data during the post-discharge period to understand what happens during that period. So first and foremost, our primary outcome is mortality. We also look at readmission. We do verbal autopsies for those that do die, so we can better understand the causes of death during the post-discharge period. And that sort of essentially frames our work. So here's a couple photos of some of our staff doing assessments. We work with a group at Children's Hospital who's done a lot of technology development around data capture. So we capture, for example, oxygen saturation on tablets that are also used to capture all of the other things that we measure, like all of the information. It gets automatically uploaded to RedCap, which is an online data management system often used for research data collection. So it's all digital. It's fairly point of care, and we have fairly high quality data. So briefly, a little bit about our results. We can go into more details if you have questions about these. So in our first study, which was 4 sites, prospective study in Uganda, we enrolled almost 4,000 children. These are children who are admitted with a suspected infection, a suspected or proven infection, who are in the age range of 6 months to 5 years. So these criteria essentially define a septic child. We did a prior study to sort of prove this. We found that 90% of these children do meet the international sepsis definitions. So this is a simple and easy to apply group that can then easily be identified subsequently for interventional projects. We found that about 4.2% died in the hospital and 5.1% died after discharge. We used this data to develop prediction algorithms. We have a lot of data scientist type people that we work with, and we have typical processes that we go through to develop prediction algorithms. We do a variety of internal validation exercises, and this has actually been more or less externally validated from a prior data set. This is a list of some of the predictors. The ones in bold actually are the ones that we added to a prior model that we had developed previously, which I didn't really talk much about. But essentially, the things that predict post-discharge mortality are first and foremost the mid-upper arm circumference, which represents the nutritional status of the child. So malnourished children are very, very vulnerable. But also acuity at admission as measured by oxygen saturation, coma score, and then prior hospitalizations and the duration of time between the current and the prior hospitalization. Comorbidities such as HIV status is important in the child and in the mother. Temperature, and then some social indicators that represent vulnerability from a social perspective. So the water source, availability of clean water, distance to facility, and the education of the mom. We did the same thing with younger children. This is a derivation cohort, so this is not a validation cohort. So while the older children was a part of a validation group, this is a derivation group. So we had the same enrollment criteria, admitted with suspected infection with this age range, and we found, like in the other study, more children died during the post-discharge period than the in-hospital period. I guess a thing that I should mention is that 2/3 or even 3/4 of all of the deaths that occur at home. So essentially, the point of discharge is the last point when most of the children who go on to die are seen within the health system. So this is really a time when we have an opportunity to do something, hopefully, to change the course of these children's outcomes. In the younger children, growth was by far the most important factor for predicting outcome. In fact, most of our variables were related to growth. So the mid-upper arm circumference, weight for age Z score, BMI Z score, were all part of our final, a part of one of our final models. And then acuity of illness at admission, as represented by oxygen saturation and tone, and then duration of illness. And this really essentially allows us to divide children into two groups here. The rock curves, which I'm sure most of you guys have been familiar with. Essentially what this allows us to do is divide children into sort of a low risk group, which in our case comprises approximately 40% of children. Actually, for the younger ones, we actually have two groups. We have a moderate, a high, and very high risk. So we have two different cutoffs. For the older children, we have a single cutoff, which represents a low and a high risk group. But essentially, the high risk groups have a very high chance of mortality, between 10 and 15%, while the lower moderate risk groups have a much lower chance of mortality in the range of 1% approximately. As I mentioned before, most of the children die at home or on the way to seeking care, with only approximately a third of children dying during a subsequent readmission. And again, this is really gives us an opportunity to intervene at the point of discharge. I guess a few take-home points here is that the transition to home is neglected. People often, whether they're health workers or patients, don't recognize that when a child is sufficiently recovered to be discharged, that they're not yet fully recovered, and that there's this period of vulnerability, which probably lasts on the order of 6 months. I guess I should mention, I didn't show you any of our survival curves, but most children who die don't die in the first week after discharge. Most of the deaths will occur more than 1 month after discharge. I mean, approximately half occur within the first 30 to 45 days. But more than half occur during that sort of latter stage. So these are children who are vulnerable to oftentimes to reinfection and to having a more severe outcome upon a new infectious illness. And I've already mentioned that this really is an opportunity. One thing that I probably should have added some slides on, given the context of this presentation, is really around what we've done in terms of building models of care to integrate into existing health systems. That's been a big theme of today, I think, is health systems. I'll talk a little bit about what we do, and we can talk a little bit more around the issues of sustainability and integration during the sort of question and answer period. But our approach, and I haven't given you all of our data, but we did do some initial work looking at an interventional program to improve outcomes among vulnerable children. And it really is based on sort of two different things. Number one, it's around education and counseling at the point of discharge. Of course, we want to train health workers. Often it's not recognized even by health workers that there's such a strong period of vulnerability, but certainly parents don't recognize this, which is often why when there's a subsequent illness, they're wondering, well, I thought my kid was better, why are they sick again? This makes no sense. Perhaps my prior care didn't have any impact and I shouldn't pursue the same kind of care, which they spent all their money on already. So the idea of understanding vulnerability as a normal aspect of recovery, recognition of danger signs, there's often delays. We saw that about 20% of all kids who die during transport. So there is often a desire to seek care, but it's too late. So recognizing danger signs early and having a pathway to seek care at the outset is really important. And then home-based care practices, things around nutrition, preventative care like hygiene, mosquito nets, etc., and then of course early and local health seeking. Our model really allows us to try to identify those most in need of follow-up care. So what we do is we use our model to identify those in whom we need to organize follow-up. So for our moderate and high-risk children, they get tailored follow-up during the post-discharge period at a local nearby health center or with a community health worker to look for things like danger signs and recurrent illness. We've also worked with the Ministry of Health in Uganda to build a facility-based discharge training program. Essentially what this is we want health workers to be aware of issues around vulnerability, what the common aspects that define a vulnerable individual are, things like malnutrition and severely ill children, so that they're aware that that there is a period of vulnerability and that they can look towards trying to find ways to improve care among those children. We've developed a facility assessment tool, essentially, that allows us to do facility evaluations to understand their capacity to have high quality discharges, allows us to identify gaps and subsequently repeat this assessment to see how those gaps are closing in after we've done our various trainings. And we've worked with the Ministry of Health to develop new guidelines and documents around provision of post-discharge care. One thing I should mention is that we've taken our algorithm and we're testing it in about 15 facilities in Uganda to see how it can be incorporated into usual care practices. So we have some money from Grand Challenges Canada, who you may have heard of, to do this transition to scale work, trying to see how we can fit our algorithm into a health system. And we've done a variety of different models. I'll briefly touch on those right now. So we've done one model where we use our own app, which we never envisioned being a final solution. And indeed it's not, but it's a way to see how does a health worker respond to the use of a prediction algorithm to assist in the provision of care. Secondly, we've integrated our algorithm into an existing EMR system that's already functioning in Uganda. This is a Ugandan startup who have developed an EMR system, and it's working in a facility, in a set of facilities in the Southwest. And we've been able to integrate our algorithms so that they can identify the vulnerable children on the back end, essentially. So even the people who are entering in the data aren't aware that this data is being used for the algorithm. And unlike with our other app, where there's a potential of duplicate data entry and where you need adoption, here it's sort of, it's involuntary. It's being entered in automatically, and those children are flagged for further care. Those are the two main models, actually. I'll skip the other one in the interest of time. And then we've also worked with the Ministry of Health to update some of the guidance documents. So they have these mother-child passports in Uganda, which are essentially are documents to help parents take care of their children and to take and for mothers to get antenatal care. There's sections in there now around post-discharge vulnerability. The Ministry of Health has produced various discharge counseling cards that now can be given out to parents and children. And they've been integrated into other sort of UNICEF-style key health practices that are also distributed to different hospitals. Our data is not just around post-discharge care, although that has been the primary purpose of it. So as I mentioned before, we have 3 time points where we collect data. And this data is very, very rich and can be used for a lot of different things. While our main model really is linking number 1 and number 3, what admission elements predict post-discharge outcomes, we have also been utilizing our admission data to predict in-hospital outcomes. So in-hospital death, for example. We are also utilizing our discharge. We can look at discharge data and post-discharge outcomes. We can look at admission data related to itself. So trying to understand different vulnerable subgroups. There's just lots of ways that we can examine this data, and there's also different ways that we can try to examine how our models work. So we're getting a bit more into machine learning, more complex algorithms versus just traditional regression. I see that my time is running short, so I'm going to probably stop there, and we can open it up for questions. But it's been a fantastic opportunity to talk with you today, and I really appreciate this chance. Thank you, Roger and team, for inviting me.
Thanks very much, Matt. Why don't we start off with a couple of questions for Matt before we open up to the general Q&A. Maria, please go ahead.
Yeah, thank you. I think what you're doing is so relevant because predictive models are such a clean, sustainable way of like solving resource allocation problems. And one of the main issues, I suppose, is data collection, but you seem to have so much rich data that I really was wondering how difficult or it is to actually establish data collection infrastructures in this setting, and maybe like considering how rich data you have, like do you see yourself transferring this like for example the use of Bayesian or models to other areas of care, for instance diagnostics or stuff like that, or even how to transfer now currently existing models that are like built upon like more big hospitals? Maybe there's a way to transfer that into low-income countries. Well, I
Yeah,
know.
I think, yeah, those are all really good points. I mean, I guess the first question is around infrastructure to collect data, and you're right, it's very expensive and difficult and arduous process to sort of begin building that. And of course, we've had a lot of different sort of funders at different times that have helped us get to where we are today. But of course, we can't indefinitely continue collecting data on this. And I think that, you know, one of the things is what we've worked a lot around trying to understand who's collecting what data, how do different groups who collect data work together to collect data in the right way. So we've built working groups, for example, around how do we define certain variables. So for example, if you're measuring temperature, you know, I could measure it in the armpit, in the axilla. Someone could measure it orally. Someone could measure it rectally. Someone could measure it with infrared thermometer. So how do we establish clear guidelines around how to collect temperature? And that's just one example. There's every other variable. So you can have different teams collecting the same data in different ways, and it makes it hard to work together with other teams. So having standardized definitions of variables is a really important part. And we've tried to look at developing processes where people doing pediatric sepsis research can collect the same data in the same way. So you can ultimately build data sharing platforms where you can combine data and improve your ability to build various models. In terms of, so we work closely with a group called the Pediatric Sepsis Collab, which is also developed at a children's hospital, data sharing platform, analytics platform, and it allows us to work with other partners all over the world to ensure that everyone collecting data is collecting some of the parts that are similar, so we can do data sharing. There's also the issue of reverse innovation. So I think Ryan might be interested in this. We've done some work around trying to understand what are these issues that occur in northern, rural, and remote communities. And we've worked with a colleague. We've collected data looking at individuals who are admitted to BC Children's Hospital, as well as in Prince George, which is another referral site for the Yukon, I believe. What predicts recurrent admissions among these children who have been repatriated back to their communities? Trying to see if we can look at who needs better follow-up care and how do you provide that and who's at risk. And so I think there's a lot of areas where there's approaches that can be applied in Canada. There's lots of problems with prediction modeling as well. How do you update prediction models in the middle of an intervention, even in the middle of a change in practice? And how do you continue to validate? How do you validate in different contexts? So will our models in Uganda work in Tanzania? So we're doing a little bit of that work currently, trying to validate some of our work in Rwanda. But I think you bring up a lot of really interesting points around how is data collected, how is it used, how is it shared, how do you build larger data sets? These are all challenges that people working in the prediction modeling sphere have to deal with.
Thank you so much.
Yeah, Maria? Oh, yeah, thank you.
Matt, I've got a question. Can you talk a little, it's actually two parts. So can you talk a little bit about some of the interventions that you've implemented as a result of the data you've collected? And also, can you talk a little bit about the impact you've had so far?
Yeah, so in terms of the interventions, we've sort of looked at it from a variety of perspectives. So one is we see that there's a major problem here with post-discharge care, and there are basic things that can be done at all sites who provide discharges, any facility, whereby even knowing who's at risk in a very broad sense can improve care. So at its most basic sense, we have gone and done a lot of work with a lot of facilities in Uganda, trying to allow them to understand vulnerability and outline the importance of the discharge process. That's a sort of a general thing. And the Ministry of Health has been very keen on this. And a lot of our facility training modules are developed around that idea. And we have a 2-day training program that we now implement. We've done it at 15 hospitals in Uganda. More specifically, we have developed what we call our Smart Discharges program, which is a very specific program utilizing our actual algorithms and linking it with a specific focused intervention, which is a risk-based intervention. So different children at different risks at different kinds of interventions. And this is what's being currently evaluated in some of our clinical studies. And we've done a proof of concept study, which has really shown that it improves health seeking after discharge by at least threefold. And it reduces mortality, although we didn't have a large enough sample at the time. Our validation work is going to give us more of that data, but even in our interim analysis, we're seeing very similar results in the first 1,500 patients, about a 25% reduction in mortality. And I think the idea that the problem of post-discharge death is a system problem. There's been at least 5 or 6 randomized studies recently published in the last few years looking at, sort of pharmacological intervention in the post-discharge period. There was one published just in the Lancet this week or 2 ago, looking at azithromycin during the post-discharge period among children who've had acute illness admissions, showing that it didn't have any impact. And I think that if you look at where children die and the context in which they die, it represents a system problem. So children are dying at home, they're dying at home or seeking care. And if you look at the kinds of risk factors that these children have, it represents an access to care problem. And there's often this idea that they've given up on care in many ways because their original care didn't seem to help, even though it probably did. So I think there's a lot of ways to try to figure out how to best intervene. And I think you can come at it from a variety of different angles. But specifically, we're looking at trying to do it around recognition of illness and follow-up among those who are most vulnerable. Because you can imagine that there aren't enough resources for every single child to get followed up 3 or 4 times during the first few weeks after discharge. But if we can find out the ones who do need it, we want to do that. And we're also doing the same thing in mother newborn dyads for postnatal care, et cetera. Kelly.
Hi, thank you. That was a great presentation. I found it really eye-opening. I'm just curious how you found your initial problem or define the problem to solve. So did you interact with physicians in Uganda or I was curious because I hadn't thought of the problem myself.
Yeah, that's a great question. I mean, I think oftentimes from our perspective here in the West, we cannot very easily identify the most important problems that need solving. And I think that we do get a lot of that from our partners in those places. So in this example, it was talking with health workers in Uganda, and then also other people who have done a lot of global health work, who have had a lot of exposure to the various contexts, saying, you know what, I feel like this is a huge problem. Kids, I think, are doing poorly after discharge. And the fact is that nobody knows. We do not have health systems in Uganda that capture vital statistics. So whereas in Canada, every person who dies is captured, and the context of their death, and you can link it to prior admissions using pop data, BC, et cetera, that doesn't exist. So people talk about community deaths and community preventative care, talking about people dying in the communities, but it's not recognized that in fact, a ton of community deaths are actually post-discharge deaths. They're just occurring 3 or 4 months later. So people are not linking the problem together. And I think that's where we can understand how health systems and surveillance can really improve care. But you're right. I mean, it's all comes from the local population. And, the things that I've learned the most in my work have come from my own team, nurses primarily, who have been, every day on the ground. We talk about what they're seeing and we come up with new ideas and new problems and finding ways to solve some of these problems.
Thank you.
Harvey.
I'm sorry, more questions. Fantastic work. And it really highlights I think, problem that exists in most of the world is that you have a limited number of healthcare specialists or clinicians per capita to a very large geographic population. And I've seen in other parts of medicine attempts at extending the reach of these clinics into the community to provide constant contact almost with patients in the community. So that it's almost like they're being managed almost like inpatients in the outpatient setting. And the technologies that enable this are around things like natural language processing, communication bots, these sorts of things where you can actually have conversations with patients that are recorded and then processed by a machine, and then keywords taken out and populated into medical health records. So you can start to pick up red flags. Like the bot could ask a mother, how's your child doing today? And, are they eating or things like that? And then the information that comes back gets processed automatically and gets flagged to nurses or doctors as they identify potential issues. They do that with diabetes now. So they'll ask diabetic patients about how whether the sugars have been like, or have they had any symptoms, or, those sorts of things. And they're able then to provide diabetic care in the community at a much greater scale than they could have, rather than having scheduled visits of people coming back and forth. And so that's an example of how I think a technology in this system may allow clinicians and experts to monitor a little bit about how things are happening in the community without having to have expensive, say, wearables or something like that you're going to put on a child, which would never exist in that situation. So for the engineers, again, start thinking about these sorts of extending technologies to really allow this real paucity of experts to deal with a bigger population that would ever be expected to happen here in Canada. So Dr. Wien, that was incredible. Thanks. I really appreciate it.
Yeah, I mean, I guess building on that point, I think it's a really good point. Like oftentimes what we'll see is when someone is discharged, the common line is come back if there's a problem, maybe come back in 2 weeks, but nobody does. And if you look at the reasons why, it's very obvious. Mom and baby coming from this community have literally spent like 6 months of savings and wages, and they borrowed money, they sold land. We looked at this from an economic perspective as well, out-of-pocket costs. It's astounding how many mothers and families are selling land, selling possessions just to get very basic care in the hospital. So it's no wonder that they can't come back. Unlike in Canada, you get food in the hospital when you're admitted. In Uganda, you don't. The mother sleeps on the floor beside her child on a mat. They have to spend money on food versus if they're in the community, they're growing their own food. So now they're spending money that they would otherwise not spend, and they've literally spent their savings for a 1-week stay. So of course they can't come back. And the issue is not that you even need to come back, because often it's the issue of recognizing danger signs. And that's what you mentioned, Harvey, about the bots. Like, what are the warning signs that would prompt an intervention? It's not like you have to diagnose a problem. You have to sort of say, are there any of these sort of warning signs that then prompt further potentially referral and all that. And we've really tried to utilize community health workers and low-level health centers for this. But I think that, as you say, we could probably leverage technology as well. One of the challenges that we've been doing a lot of work around SMS messaging for reminders, also for communicating. There's a huge technological problem that we're facing right now is how do we communicate? How do we connect different levels of healthcare? This is like the holy grail of global health. Can you properly connect a higher level health center to a lower level health center to allow them to communicate? And better yet, even to the village health team, the community health worker. And the big challenge around, of course, is cost. SMS messaging is expensive. There's different kinds of phones. People have phones more and more often, but the messaging obviously costs money. How do you develop this in a way that can be done more sustainably? There's so many complicated pieces around this, and of course, how do you detect those those warning signs that would then prompt further investigation?
I'll just add to that. There's insurance models that you can use to incentivize that behavior that are sponsored by telecom companies. So we've implemented that in the slums in Nairobi, where Safaricom, the largest, that invented M-Pesa, will also incentivize health interactions by SMS, which allows patients to have data plans that are somewhat subsidized so that they can do what they need to do and get into the world. And if they happen to be doing it to do healthcare decisions or healthy behaviors, they get some credits back to do that. And so it becomes a healthcare insurance model that where one didn't exist before, using a service that everybody wants to use anyway. So there's lots of different systems that the technology then can plug into.
Yeah, I agree. I've seen the same thing with insurance. In the place where we've implemented our algorithms into the EMR, that's linked to our health insurance scheme for that community as well. And then our interactions primarily with the health insurance leads of the community, not with the village health team people, because there's already linkages established. But that's only in one small part of Uganda, and it's not really a current thing that you can spread out beyond that. But that's a super good point.
Yeah, and it also gives them an identity. Many of these people are undocumented. And it helps the country, but it also helps these people have an identity which they can start to build and get services and get jobs and those sorts of things. So it's all knock-on effect, all from simple SMS technology.
Harvey, how is that tracked? How do they know what is being used for health purposes?
So the way we've had to do it is we've had to have key partners and stakeholders that are our clinics. And so if there's interaction between those numbers, that's considered a healthy interaction. So if you book an appointment for your child, for example, that's considered an interaction that gets credit for it. And as you build it more, certainly as you start to go out of the SMS realm and into the internet, it becomes much easier to do that.
Mm-hmm.
Very cool. Yeah, let's open up questions to all three of our speakers. Shirley, please go ahead.
Thank you. First, I'd like to thank all the guest speakers for talking to us and giving us this informative session in today's seminar. And also, so just to preface this, I'm from Kenya, so I'd like to also thank you for your work in the Kenya Trauma and Injury Program, and also the work that you've done. And not just Kenya, but Uganda, which is our neighboring country. And so a question I have is, how do you follow up or evaluate that these systems and these systematic changes that you have put in place are still in place and effective? Because, and then I'd also like to also open this to the general, to everyone. And the question would be, when you're trying to put these systematic changes, you have to navigate the local culture and politics. And so what are the challenges in doing so, and how are you finding these linchpins or people to connect to? For example, how do you just suddenly talk to the Minister of Health? And then there's also the issue of corruption, which I'm sure you might have run into. And so how are you first targeting and starting these projects?
If I can start by, that's a really good question. I didn't get into a lot of that, but I think, so we have a very close partnership with an NGO in Uganda called Walimu. Walimu is an NGO focused on training health workers, and they are they're very closely linked with the Ministry of Health. The director, I'm actually on the board of directors, but the director of Walimu is the previous Director General of the Ministry of Health. He's a really fantastic human being, one of the best people that I know. He's sort of an elder statesman, without the proper linkages. And I started out, and I still am, part of the academic system in Uganda, but you cannot make sustainable change through academic institutions. It just doesn't work. You have to find the right partners, whether they be NGO or for-profit partners or whatever. You have to find the right partners. You cannot do it as a foreigner because you're not, I mean, I lived there for 7 years. You can't do it. You have to have the right partnerships with the local people who are real change agents in that country. So we work with a technology company called iStreams in Uganda. They're a local startup. They've succeeded very well in the sort of the EMR system and insurance world. We work with this NGO called Walimu, which is run by people from the US but primarily from Uganda, and the direction is from people in Uganda. So I think partnerships and stakeholder engagement. Probably a third of all of the funding that we got from Grand Challenges Canada, which is around this transition to scale, was around stakeholder engagement. We had a variety of stakeholder meetings keeping people involved. So many of the decisions made at the policy level are made by these technical working groups who have representatives from private industry, from other hospitals, from other leadership areas like UNICEF and WHO and other things. And you have to engage each of those people individually outside of that context to build alliances. It's like playing a game of chess. So I can't emphasize more that this cannot be an academic exercise, because academics will get you nowhere for actual change. You have to be engaged with partners who want to make change. That's my 2 bits on that.
I'll add, and I couldn't agree more. It is unethical for me to show up in a country and tell them what to do. And if it's in the medical context, it could be considered assault or attempted murder if I'm actually operating on somebody. So I cannot do that. What I need to do is learn the problems that they have, understand them in a way that is very difficult to do as an outsider, which means you have to live there, you have to spend time there, and then get invited to help. I can't go knock on the Minister of Health's door. I've done that. And they just look at you like you're nuts. Like, why is this person standing in my office, and how do they think they know what they're doing? But that's the approach that a lot of us in the West have taken in quote, helping Africa or the developing world or whatever you want to call it. They're no different than us. You'd be surprised how innovative they are and how much they want to help their people. It's incredible. And they're more dedicated to it than I think a lot of politicians and minister people are in Canada. They're passionate about it. They've had to survive the resource limitations and the budget limitations, and they still stick with it because they want to help. So it behooves me to go and ask them, how can I help? If I can help. If I can't help, then it's not on their radar. I'm not going to force my agenda on them. I need to do something else and find somebody else I can help. I mean, there's so much to do in the world. That's not a problem. So I agree. Academics are good at validating solutions. They're not good at implementing or coming up with solutions. So it's got to be out of the academic world. Engineers are fantastic at coming up with solutions. But again, like I've said, they have to fit in the larger scale, in the larger scheme of things. Clinicians are fantastic at going in and thinking we're going to save lives. But I can't do that in a parking lot. Like, I have to have a system in which to function. And so I agree. Ministries of health are where it's at. I can't go, to go into any country and provide medical services or change the medical system without engaging the Ministry of Health is tantamount to an act of war, I would think, because they are the ones that determine their country, and they are the ones that know what their country needs best. And they are the ones that understand the resources and how to do that. Our job is to go in and ask, how can we help? And then provide that help and deliver on what we're going to say. And our motivations cannot be for publication, pictures of Black babies, all the things that we've seen, unfortunately, in the past. What we really have to do is help them and help their people in the way that they want us to. And I can't stress this enough. And it's so frustrating to see the past 50 years of dead aid in these countries and the trillions of dollars wasted and the people that still died in the name of colonial help. And so I actually will invite all of you to come to our Bethune Roundtable, which is a global surgery or global health event that's happening here in Vancouver this year. And the actual theme of it for the first time in as many years as been there is decolonization of health. And so we're going to be talking a lot about who are we to land in a country and impose our views on them. We should be there. We should be asked and invited to come in and help the best way we can.
Can you give us details on that, the event, Harvey?
I'll send it out to you shortly.
Awesome, thank you. Brian, you've got your hand raised.
Yeah, I was going to say, and a lot of these issues that we're talking about are also relevant here in Canada. And you look at how the Indigenous populations of Canada have been treated and health solutions have been imposed upon them. And this isn't an Indigenous specific one, but most of the receiving end are Indigenous people, but even up in Northwest Territories, Yellowknife developed a colon cancer screening program to be applied to the Beaufort Delta region where I live, but we weren't involved in any of the planning. And I found out about it sort of third hand through a random conversation. And I'm like, what? Like, I'm one of the people who will do the colonoscopies for all of the people identified is having blood in the stool from the screening test. And I wasn't involved in any of the discussions or anybody in our team. So, I mean, that's just here within Canada. And you'd think we would know a bit more about that. But anyway, it's just interesting times when we look in our own sort of backyards or front yards. Rules shouldn't be always in the back. You know, things that are still happening here. And so it's sort of, it's good to reflect on what you're mentioning, Harvey. And early this year, the Bethune Roundtable was about more focusing specifically on Indigenous health. And just also thinking about the Truth and Reconciliation Commission, the TRC, and what it's trying to achieve. And also thinking about those kinds of partnerships.
Fantastic. Any more last questions or comments before we sign off for today? We're at a few minutes after time.
I think there was a question, a comment. The last one was also about corruption. I didn't actually respond to that, but I think that takes a whole separate session. Huge problem, huge. It's unbelievably huge. So, but I think we don't have time to get into that right now.
But also don't let it scare you.
No.
Okay, thank you, everyone. I'd like to thank our speakers once again today, Dr. Haas, Dr. Falk, and Dr. Weens. And thank you so much for your great talks and for the great discussion. Thank you to everyone for attending today and for your questions. Yeah, with that, I'd like to close the session for today, and I wish everyone a great day.
Thanks, everyone.